Welcome to London Valve 2025. My name is Nina Wunderlich, I'm from Germany, and I'm here with Patrick Calvert from Cambridge. So we would like to discuss a little bit about mitral paravalvular leak closure. So Patrick, why is this an important topic for PCI London valves?
Well, Nina, you know paravalvular leaks are not that rare, particularly in the mitral and the mechanical valves. They can occur in up to 15% of operations, so they're not a rare thing at all. And obviously, we want to treat all the problems that our patients are presented with the increased interest in percutaneous management to the mitral valve. People are more familiar with that territory, with the tool set, so it's really important that we learn to treat this in an effective manner. Nina, can you just tell me any thoughts about really why these occur in the first place, paravalvular leaks?
Yeah, to my experience, it's most likely infective endocarditis. So this can be an ongoing process. So we've seen, for example, a case today where occluders were placed around the mitral valve, and then 6 months later you realize, well, this process is ongoing. So in many of these cases you will find infective endocarditis, and this is an ongoing disease. And on the other hand, you might have just suture dehiscence. You have to suture in soft tissue. So it might happen that the suture is not so tight and not so well in place, and you can get a leak there. On the other hand, I would have a question for you, Patrick. So which patients? You have a lot of experience and intervention. So what are the patients you don't treat for paravalvular leak closure?
I mean, I think that's the right way to put it, because the truth of the matter is, for us, is now the default treatment, a percutaneous approach with paravalvular leaks. So to think of the ones we don't treat, well, obviously, if the leak is mild, then we're not going to treat that. If the patient has an infection on board, for me, that's an important contraindication. Yes, you might reduce the leak in the long run, but really, the device is going to get infected, so that really isn't one. And then, obviously, if the valve is mechanically unstable, if it's rocking, if it's dehisced, really, I think once you get much more than 30% of the sewing ring is dehisced, then I think it's going to be difficult to get an effective long-term dural approach. So really, mechanically unstable valves and infection are the two big contraindications. One of the problems we have with paravalvular leaks, Nina, really is that they're really complicated, they're hard to image. So something I'd love to ask you is, can you tell us a bit about how you assess or define a severe paravalvular leak?
I agree. It's not an easy task because most of the leaks we are addressing are not circular, they're not round, they're more crescentic in shape, they can be oval formed. So to my experience, the best approach is to take a 3D vena contractor area, which really gives you an impression about the shape of this paravalvular leak. So at the moment, we might have better imaging modalities in future, but at the moment, I think the best approach is to go with a 3D vena contractor area. And the values you get from there, you can adapt it to the native valves. Yeah, so for example, if you have a 40 square millimeter for a regurgitant area, so you can compare that. So this indicates this is a severe leak in this patient. So Patrick, imaging is crucial during these procedures. Can you give us some tips and tricks why, and in which cases, in which situations do you use imaging?
Oh, I mean, enormously crucial. I mean, first of all, if we just talk about the preparation, I mean, really that's where you do a lot of your work in advance. You want to have a very clear idea of the anatomy. You want to know exactly where the leak is, how big the leak is, are there sutures that are retained that's going to influence your approach. You want to know, because I would say almost without exception, the approach is always transseptal these days. You can get good information from your imaging about your transseptal puncture. If you are going to have a septal leak that you're attacking, then you want to be quite low down. You want to be in line for the posteriors. You get all this information both from 3D TOE, obviously from CT can be helpful too, and of course the transthoracic will give you important hemodynamic information. All that important assessment in advance will put you in a strong position when you come to do the procedure, such that when you have the procedure, and by the way, 3D TOE is mandatory, in my opinion, for these mitral paravalvular leak closures, it should not be a difficult procedure. You should have done the hard work up advance, and then the guidance will be there to help you it's a teamwork. It's like a dance partnership together. You've got to communicate well together, understand exactly what to expect from one another, and get a good assessment of size, deployment, check there's no interference if it's a mechanical valve, and then it's job done.
So Patrick, I think we agree that mitral paravalvular leak closure is a big and important topic, and it should be here at London Valves. So the patients are not rare. So we have a couple of patients, you said, Patrick, in between 5 to 15% of the patients will occur with a paravalvular leak. So it's not a rare disease. And we have to offer some treatment for these patients, obviously. And we can't ignore it because, I mean, it belongs to the field of mitral interventions. So it completes the portfolio, and therefore I'm very happy that mitral paravalvular leak closure is back as topic at London Valves.